At the John A. Burns School of Medicine, we're really glad to have you join our monthly Geriatrics Echo. If you've never joined us before, we run this series on the second Wednesday of every month from 12 to 1 as a 1-hour session. We get a short lecture from an expert, we share expertise from the rest of the team, and then open up a time for case discussions. We invite you to share any geriatric cases, even if they not be on the topic at hand. Our team is willing to teach and share our collective wisdom with you. We only ask that you keep it HIPAA compliant for case discussion. And of course, those who present a full case have the opportunity to receive a $150 gift card, courtesy of Echo from UH. So this is a CME activity sponsored by the HCCME, a joint venture between the Hawaii Medical Association and JABSOM. This program is also approved by the National Association of Social Workers, and you can get up to 1 hour of CE credit for social work. And as a reminder, you must complete the evaluations in order to get your CME or CEs, or certificates of attendance. And the evaluations can be found on our website under the evaluations tab or by following the link in the chat box. So just ask you to enter your full name and credentials of everyone in attendance in the chat box so we may keep attendance. Okay. As you know, all sponsors of CME are required to execute a conflict of interest policy, and speakers are expected to disclose to the audience any real or apparent conflicts of interest that have a direct bearing on the subject matter. And Dr. Hayashi, here today, has disclosed that he has no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. So today's topic is the dialysis decision, nephrology in older adults. So I'm pleased to introduce our speaker, Dr. Rick Hayashi. He is a JABSOM graduate who completed his internship, residency, and nephrology fellowship training at UCLA. He also did a kidney transplant fellowship at SUNY Brooklyn. He practiced nephrology at Tripler and the VA for several years and now has his own private nephrology practice since 2016. He has won Excellence in Teaching Awards for medical trainees over the years, and we look forward to his teaching us today. I also want to introduce the rest of our interdisciplinary team. We have Mary Gatto, Department of Public Health Nursing. We have Noreen Wong, so First Vitals, social work in the community for many, many years. And Chad Kawakami, he's Associate Professor of Pharmacy at the UH. And finally, just a few echologistics. Don't forget to stay HIPAA compliant, and we can discuss cases without identifying information. There is a mute button at the bottom left-hand corner. Make sure it is on, otherwise we will hear paper rustling and extraneous noise. Just unmute yourself when you want to speak up. Also, there's a chat box, and if you press it, will bring, you can fill in your name and location so that we can keep attendance. And if you are joining by phone, you don't have a chat button, just unmute yourself and introduce yourself. Okay, so go ahead, Dr. Hayashi. Thank you.
Thank you, Dr. Wynn. Thank you, everybody, for coming today and for inviting me to speak. This will be a short presentation on renal replacement therapy in the elderly. And the fountain of youth, something that we are all striving for. I mean, the stories of the fountain of youth have been around this century BC. Ponce de Leon in Florida thought he maybe found the fountain of youth. But, aging is a part of life, and we are all aging, including our kidneys. Chronic kidney disease, or CKD, is a disease of the elderly. This study shows that no matter how you measure the glomerular filtration rate, or GFR, roughly half of adults over the age of 70 will have some degree of chronic kidney disease. And GFR was shown to decline by about 10 ml per minute per decade after the age of 40. So every day that we all age, we are slowly developing chronic kidney disease. And because of this, CKD is largely a problem of older adults, but it can affect anyone in any age population. Why do we see more chronic kidney disease in older adults? Well, first of all, there's a clustering of diseases that occur as we age. For example, the end results of diabetic, long-standing diabetes, hypertension, as well as more uncommon diseases like multiple myeloma, encapsulitis, anti-glomerular basement membrane diseases, amyloidosis, myeloma, diabetic nephropathy, membranous nephropathy. These diseases all peak in elderly patients and older patients. There's also the cumulative effects of acute and chronic kidney insults. I liken this to our football players in the NFL, where they get these subconcussive brain traumas, throughout a 5 to 10 year NFL career, and by age 50, they have full-blown dementia. The same thing occurs with our kidneys. That CT, IVP you got when you were 30, the cabbage that you got when you were 55, the TAVR at age 65, another CT scan with IV contrast at age 72. So the cumulative effect of all these subconcussive renal insults add up, not to mention the long-term effects of high blood pressure, diabetes, obesity. They all kind of come to head as we get older, as we reduce our renal reserve. And then there's kidney senescence, just regular age-related structural changes in the kidney that lead to chronic kidney disease. Histologically, kidney aging looks like this. You see glomerular sclerosis, so that circular structure in the middle there, that is a glomeruli, a very old glomeruli. You can tell by the thickened walls and the scarring in the glomerulus. You see fibrosis and atrophy within the kidney tubules. These kidney tubules that surround the glomeruli look very thinned and atrophic. They should be plump and healthy cells, but they're not. You can see a lot of fibrosis in the interstitium there. Why this happens, there's a lot of both intrinsic and intrinsic factors that contribute to this, various cellular processes and epigenetics, as well as individual aging genes like IGF-1, Klotho, and then the target of rapamycin. These all have been implicated in kidney senescence. Because of the increased clustering of CKD in elderly populations, we are going to expect more end-stage renal disease, which is the end-stage manifestation of CKD. Interestingly, though, the number of elderly patients over the age of 75 has leveled off since 2010. In 2010, there were 1,800 per million per year who started dialysis, patients over the age of 75, whereas in 2015, that number decreased to 1,600 per million per year, and that's the lowest it's been since 1999. We're not quite sure why that is occurring. Are more people maybe declining dialysis? Are people maybe dying before they can develop kidney failure and need dialysis? It's hard to say, but the numbers of elderly patients have been declining as far as needing dialysis. So case one, 94-year-old local Japanese male, 442nd veteran, has stage 5 chronic kidney disease, hypertension, as well as mild dementia. His creatinine is 6.4, which leads to an estimated GFR of 7 ml per minute. His BUN is 86. He has some mild hyperkalemia with a potassium of 5.4. He has a metabolic acidosis, CO2 is 18, and he has 1.3 grams of proteinuria. He has what could be perceived as some early uremic symptoms, some mild nausea, some itching, and a metallic taste in his mouth. He does complain of a decreased appetite. He has been losing weight because of that decreased appetite. Functionally, he is ambulatory, but he has an unsteady gait, and he's actually fallen several times in the past month. He lives in a care home. He has a son who visits once per week. So I open it up to the panel. Would you offer dialysis to this patient? Or would dialysis be contraindicated? I mean, would it improve his quality of life? Would we? Do we? Or do we say no? You're too old. Are we like socialized medicine where we ration dialysis and
Is he asking for it?
Right.
Yeah.
Well, that's a good question. Yeah, we'll get into that.
And we'll assess where he's at. Because if he's asking for it and his quality of life, what he wants, what's his goals.
Right. Actually, that's a really good point. So it is a shared decision-making process. And what is his expected survival? If he asks, Doc, what's the likelihood that I'm going to be alive in 1 year? Do you think it's 90%? Maybe 50%, 50-50, or maybe closer to 25%? Any ideas?
I don't really have any ideas, but I think what we're all trying to get at is, within the geriatrics, we talk about the Hartford, the 4 M's of, what matters, And I think that's the M, I think that would perhaps be in play here of like what matters to the patient.
Mm-hmm.
So, quality of life assessment and all the
Right.
questions that we're asking here
Yeah.
would all funnel into that yes or no.
Yeah, yeah. So I mean, there is no clear-cut answer, and it's very patient-specific. And I think there's a lot of assessment and thought and discussion that need to be involved when making this joint decision with the patient. If dialysis is selected, which modality should we choose? I mean, with this 94-year-old patient, should we offer him kidney transplant? I mean, that would be the preferred form of renal replacement therapy, but is that an option on the table? Do we do in-center hemodialysis, home therapy? Anyway, some things to think about. We'll go into a little more detail later. So anyway, in this discussion, he tells you he would like to live for at least for another 8 months until his great-granddaughter graduates from high school. So I think in this situation, I definitely would offer dialysis. I mean, there's a meaningful endpoint. He has. It sounds like even though with some mild dementia, there is some frailty, but he still has a fairly good quality of life, and there's a reason why he wants to survive. I think without dialysis, he would probably pass away prior to the 8-month period when his daughter would graduate, and I think dialysis would allow him the best chance to survive to his granddaughter's graduation. So different modalities, like we talked about, there is kidney transplant, there's traditional in-center hemodialysis where you go to a dialysis unit, typically 3 times a week, dialyze anywhere from 3 to 5 hours during each session. And then there's the home therapies, which we are trying to shift more towards. There's peritoneal dialysis, and then even newer home hemodialysis. As far as epidemiology, in 2015, when you look at patients over the age of 75, a majority of patients, 94%, chose to do in-center traditional hemodialysis. A minority, only 6%, chose to do peritoneal dialysis, and even less, only 0.1%, were given a kidney transplant. And even at age 75, patients can still get a kidney transplant. However, those patients probably had been on the wait list much longer. I personally would not put somebody on the kidney transplant list who was 75. But if they had been on the list, say, at age 68 and waited 6 or 7 years and finally got their transplant at 75, that's probably that 0.1%, because, kidney transplants are a very scarce resource. And, if a patient is elderly, demented, frail, the chances that they would fully utilize that scarce resource becomes unlikely. And you want to try to allocate, as far as the benevolence for all, you want to allocate the scarce resource to people who can utilize it the most. And unfortunately, being very elderly, over the age of 75 or 80, you probably wouldn't realize the full potential of that kidney transplant. So I think kidney transplant is pretty much off the table for this patient and for a lot of patients who are elderly. But yeah, just to know that traditional hemodialysis was kind of the predominant mode of renal replacement therapy for patients over the age of 75. So what about the outcomes? Well, this is kind of a landmark study done in the New England Journal in 2009 by Tamura. She's a geriatrician. I think she's at Stanford, looking at the functional status of elderly nursing home patients, both before and then looking at the trends in their functional status before starting dialysis, at dialysis initiation, and then for the year following dialysis initiation. And what they found was at 3 months, 61% of patients had either died, so about a quarter of them had died by 3 months, or had a decrease in functional status. By 6 months, obviously it got worse. By that point, 78% of patients had either died, and at 6 months, roughly half of the patients had died, or had a decrease in functional status. And then by 1 year, 80% had either died or had a decrease in functional status. So this table here kind of represents a predicted trajectory of a 75-year-old nursing home level resident. That dotted line in the middle of the table indicates dialysis start. The blue line represents functional status. So as you can see, there is a gradual decline in functional status prior to starting dialysis, and then there's a precipitous drop in functional status after initiation of dialysis. The yellow line after initiation of dialysis, that represents cumulative mortality. And as you can see, cumulative mortality dramatically increases after starting dialysis. So the summary of this paper basically indicates dialysis can preserve life, but it does not restore health or functional status in elderly nursing home residents. Other studies have validated this finding. There was a study in JAMA Internal Medicine in April 2019, a more recent study. And this one actually included all patients. So previous studies looking at survival in dialysis patients excluded patients who had died during hospitalization, where dialysis was started, but they never survived to discharge. They also previous studies excluded patients who died within 30 to 60 days of initiating outpatient dialysis. So this was a unique study in that it included all comers, including patients who initiated dialysis in the hospital but died prior to being discharged and never started outpatient dialysis. And they found similar results. By 30 days, about a 22.5% of the patients died. Within 1 year, a little over half the patients had died after starting dialysis. And what they found was some of the poor prognostic indicator included some of the older you were, the worse your outcomes. Initiation of dialysis in the hospital, and then a high burden of comorbidity. And this table here summarizes what they found. Basically, again, just being older increases your risk of death. Functional status, poor functional status, a higher burden of comorbidity, and then initiation of dialysis in the hospital. But this basically shows the survival difference between patients who had those risk factors, and you can see there was a significant decrease in survival if you had any of those risk factors. What about dialysis versus conservative care? So I have patients who refuse dialysis, and and it doesn't mean that I give up on them. I'm still their nephrologist. I still take care of them, but we do everything just short of dialysis. So there was a study in CJASN in April 2016 that looked at basically, this was not a randomized controlled trial. This was a retrospective trial. So because of that, it's not the perfect study. But what their observations were that there was an improvement in survival in patients who did choose dialysis versus those that didn't choose dialysis. Overall median survival was 3.1 years in patients with dialysis versus 1.5 years in those who chose conservative care. And this was statistically significant in patients over the age of 70 years. However, the interesting thing was in patients over the age of 80, there was no survival benefit, at least in this study, in patients who chose conservative care versus initiating dialysis. Multiple studies, again, just supporting the very poor outcomes in patients who are elderly and initiate dialysis. Very high mortality rates, very pronounced decrease in quality of life as well as functional status. And again, determinants of poor survival, so physical frailty coming into dialysis, age over the age of 80, poor nutritional status, late referral for dialysis, so patients who basically see the nephrologist for the first time the day they need to start dialysis, they usually have a pretty bad outcome. Inpatient dialysis initiation is a risk factor for mortality, and then significant medical comorbidities, particularly cardiovascular disease. Okay, so he started in-center hemodialysis. He lived for another year after starting dialysis and actually was able to see his granddaughter graduate high school. He continued dialysis even after she graduated for several months, but eventually did have progressive functional decline and decided to terminate dialysis and died in hospice care after choosing to terminate dialysis after a couple of weeks without dialysis. So I think that was a really good story. I think he died on his terms. He accomplished what he wanted to accomplish with dialysis, and he passed away on his terms. He didn't prolong or have a protracted course. Case number 2, 87-year-old local Korean female who has stage 5 CKD. Her creatinine was 7.8, GFR is 5, B1 is 96, and she was uremic. She had overt symptomatic uremia. And she lives with her elderly husband and her daughter, who is an internal medicine physician. She was initially started on assisted peritoneal dialysis, so she wasn't able to do her exchanges, so her physician daughter did her exchanges. She worked part-time. And so initially she was on full-blown peritoneal dialysis, 5 exchanges per day, 1.5 liter fill volumes. and just was doing very, very poorly. Was actually doing worse after starting PD than she was before. Her blood pressures prior to starting PD were typically in the 160s to 170s. But after starting PD, her blood pressures went down to normal, but I think was maybe a little too low for her. Blood pressures in the 120s to 130s. When the blood pressures were in the 120s, she would be barely arousable. She wouldn't eat. She was lethargic. She wasn't interactive with her family. So we decided to do, first off, this is assisted PD. So obviously she cannot do her own peritoneal dialysis. And there is evidence to support the use of assisted PD if you have somebody, either a paid caregiver or a family member who can do it. But outcomes, according to this C. Jason study, showed that outcomes with assisted PD versus self-peritoneal dialysis were basically equivalent. So there is evidence to support assisted PD as a viable means of home renal replacement therapy. So what we did was we reduced her. With both peritoneal dialysis or hemodialysis, we have targets. We have minimum recommended targets for clearance, for volume control, and we are actually judged by the federal government. We are surveyed by the federal government, and if we don't meet these targets for our individual patients, we get penalized, and we have to report our data. And it's important because these are quality outcomes that are mandated by CMS. But in certain situations, you got to treat the patient, not the target. And I think with her, although full-blown PD was needed to meet the numerical target, I don't think it was right for her. So what we did was we did something called incremental dialysis, where we did basically half the recommended PD. So her target numbers were not met, her adequacy was not met, but she did better. When we reduced her PD intensity, we were taking less fluid off, she perked up, her blood pressure was higher, she started to eat more, and and it was enough PD to lessen some of the uremic symptoms that she initially had, but not so much PD where she felt washed out. Incremental dialysis. So it's okay, it's a shorter, less frequent treatments that do not meet minimal dialysis clearance thresholds. Incremental dialysis is easier to administer with peritoneal dialysis. And then there's a lot of benefits to doing peritoneal dialysis. First off, patients can do it at home. Hemodynamically, it's a lot more gentle than hemodialysis. And there is a longer preservation of their native residual renal function with peritoneal dialysis. And that residual renal function lasts longer when you do incremental dialysis. So it's something that seemed to have worked for her, and it's an option for our elderly patients who do want renal replacement therapy, but maybe cannot tolerate full-blown dialysis. Case number 3, an 84-year-old frail Japanese female. She has end-stage renal disease from light chain deposition disease. She has severe compression fractures with severe pain during transportation to hemodialysis, and then really severe pain from being immobilized in the very uncomfortable dialysis chairs for the duration of her dialysis. She would be often moaning in pain in the dialysis unit and would demand to come off dialysis because of severe pain in her low back from compression fractures. So her granddaughter was really supportive and was willing to do home hemodialysis. So with home hemodialysis, this was much better. We have much more flexibility. We do shorter, more frequent dialysis at home. So she ended up, instead of a 4-hour, 3 times a week, we did 2-hour home dialysis treatments 4 days per week with flexible scheduling. She could do it in her bed or in her favorite recliner chair at home in her living room. And what we noticed was after transitioning her to home hemodialysis, her appetite improved, her energy and mood improved, and she just felt more positive about continuing dialysis. So this was a really good option for her, transitioning her from traditional 3 times a week dialysis to shorter, more frequent home hemodialysis. The last case, case number 4, my 76-year-old Samoan male patient, stage 5 chronic kidney disease from diabetic nephropathy, creatinine of 7.2, GFR of 7, B1 of 86, hyperkalemic with potassium of 6.3, bicarb of 12, phosphorus very high, 10.2, low calcium 6.2, and a very elevated intact PTH level. So commonly we will see secondary hyperparathyroidism in patients with advanced CKD. He has uremic symptoms, he's itching, he has taste changes, taste alterations. as well as anorexia. And he absolutely refuses dialysis and explains that he has lived his life. He has had family members on dialysis who have suffered, does not want to put his family through dialysis, does not want to go through dialysis. So he has decisional capacity to make this decision, and I respected that. We respect his decision to refuse dialysis. But like I told you earlier, just because they refuse dialysis doesn't mean we no longer care for them. There's still a lot that we can do. So this is the conservative care of ESRD, and basically it's medical management of ESRD, but without dialysis or transplantation, so without renal replacement therapy. This should be considered in patients who may not gain meaningful benefit from renal replacement therapy or who decline renal replacement therapy. Okay, so our focus is on quality of life, and in particular, so patients with advanced CKD will universally become anemic, right? The kidneys make erythropoietin. When the kidneys fail, there's no erythropoietin, they will get anemic. And so anemia can impact quality of life. So we use intravenous iron, we use erythropoietin judiciously to try to prevent symptomatic anemia and fatigue and other symptoms associated with severe anemia. Patients can get severe bone disease. We talked about his elevated PTH, right, of 864, his very high phosphorus of 10.2. That actually can become symptomatic. When your PTH is that high, you will get pathological fractures. When your phosphorus is that high, you will get phosphorus deposition in your skin, get severe itching, you can get calciphylaxis with phosphorus is that high, and that is extremely painful. It can affect quality of life. So we want to control bone disease primarily because of, for comfort reasons. We want to avoid pathological fractures. We want to avoid severe symptomatic hyperphosphatemia. And we have medical measures to control that. Phosphorus binder therapy, active vitamin D therapy, calcimimetic agents to control these issues. Metabolic acidosis, remember his CO2 was 12. Metabolic acidosis can accelerate kidney function decline. Metabolic acidosis can also worsen bone disease. So we want to correct metabolic acidosis using, bicarbonate replacement therapy. Hyperkalemia, no, he doesn't want dialysis, but he doesn't want to die of a cardiac arrhythmia either, right? So treating hyperkalemia so that he doesn't die of a fatal arrhythmia can prolong life in patients with advanced CKD. So I usually send these patients to a dietitian, and then we use potassium binding agents. We used to use Kayexalate in the past. I don't use Kayexalate anymore. I will use Deltasa, which tends to be more palatable. It's a calcium-based potassium-lowering agent that doesn't cause the diarrhea that you typically see with Kayexalate. So I will often have them on a low-K diet and then Deltasa, chronic Deltasa therapy or patiromer therapy to maintain their serum potassium. Volume overload will often occur in patients with advanced CKD, so we want to use diuretics to prevent pulmonary edema or uncomfortable peripheral edema, because that can affect quality of life. Okay, and these recommendations, this is what we do. And if you want a summary, there was a review article in CJASN on basically conservative care in patients with advanced CKD who refuse dialysis. So his uremic complications were medically managed. We use sodium bicarbonate, phosphorus binders, active vitamin D therapy, dietary restrictions, diuretics, uric acid lowering, and erythropoietin. And he survived for 5 months and eventually died in home hospice. So in conclusion, the mortality rate in elderly patients after starting chronic dialysis is high, and less than 50% are alive after 1 year on dialysis. Studies have shown that in patients who are very old, over the age of 80, dialysis actually does not offer a survival benefit versus conservative care. Physical function often declines rapidly following initiation of chronic dialysis. So it's something that we do need to consider when we do start our elderly patients on dialysis and prepare for that. And I think that, like we discussed earlier, it's a shared decision-making process in elderly patients. It's not a panacea. It will prolong life, but it doesn't restore health. And mortality is still very, very high after starting dialysis. And so in patients who opt in for dialysis, these things need to be disclosed. And it has to be a shared decision-making process. And then options for elderly patients who do start dialysis. You know, it's not just one size fits all. It's not all in-center 3 times a week dialysis. We have incremental PD, we have assisted PD, we have home hemodialysis therapy as options for elderly patients who elect renal replacement therapy. And that's it. Any questions?
Can we close screen sharing?
Great. Any comments from our team here?
Give us a second, we'll pull up the chat to see if people are asking questions on there.
Great to see so many participants. Anybody have any patients with kidney disease? I'm sure you must. Any anecdotes or stories you want to share? Questions? So I want to pose a question maybe to social work or public health nursing. What are some of the challenges that you see in patients that you're seeing in the community with renal disease that need your support?
I think it's good for the public health nurses to make the home visit and see how they're doing with medications and how their setup is. Can we do anything to make the environment more comfortable for the elderly person? And make sure that they understand about their medications and taking them the way the doctor expects them to, and then communicating back to the doctor if that's not happening. And I think with the family, just helping them have the conversations about what they really want and what matters to them sometimes is helpful. And listening about because all the symptoms like this itchy and cranky and all those kind of things, just trying to be supportive about those things.
I think it's a really big decision to make. So the more information they have, they can make a more informed decision. A lot of times it's not isolated only to the patient themselves because it involves the family. And so with the, like you said, shared decision, it's so critical to have the patient and the family with the physician. And sometimes we find discrepancy between what the patient wants and what the family wants. And so that part can be a challenge, but with more information and I guess outcomes I think the decision is better made and it's more consistent. So this is really good. And the fact that you folks, the physicians will care for a patient who opts not to go on dialysis is really perfect to work with the symptoms because, like you said, it does progress.
And we can also talk to them about the benefits of having in-home hospice and, comfort measures if they choose not to do the dialysis.
I think we better add that to our advanced care plan now. Okay, so if I have CKD, then I know.
Part of the discussion, Yeah, so we have a few questions on the chat box. Marcus Pang, please talk more about the pros and cons of peritoneal dialysis. You want to?
So for a lot of our elderly patients who may have cognitive issues or functional issues, they may not be able to do their own peritoneal dialysis. So one of the cons would be exactly that, is they cannot do their own PD. But if they have a support person who can do the PD for them, I think it's a really good option because it allows for incremental dialysis. It's a home dialysis therapy. Another con with the peritoneal dialysis is placement. Nursing homes will not allow peritoneal dialysis. So if a patient needs to go to a SNF or a rehab, they cannot do their PD. They will not do their PD there, and so they will have to be transitioned to hemodialysis. So maybe a benefit of doing hemodialysis would be if you did need placement. Or, for example, if you're a caregiver, let's say a person is doing PD, but then their caregiver falls and breaks their hip and can't do PD for them. There's no backup for PD. There's no in-center backup. Whereas if you're doing home hemodialysis or hemodialysis, you always have in-center to fall back on. And then when you're in a nursing home, you can go to the nursing home and then go to outpatient hemodialysis, whereas PD is not a viable option. So, so those things should be considered. I mean, I think a lot of logistic issues. As far as physically, I mean, studies don't really show significant survival benefit of one modality versus the other. So, when I recommend a dialysis modality, a lot of it really is tailored to the patient's, logistical issues and lifestyle and things like that, and what would fit them best, because there really isn't much survival difference between PD versus HD. I mean, there might be some subgroups that, for example, like women, younger women, there might be some survival difference, but it's not been borne out as far as large-scale clinical trials, as far as a huge survival difference between both modalities of renal replacement therapy. So those would be some of the issues to think about when deciding, is there a caregiver who can do the PD? Is there a chance the patient's going to be in a nursing home, in which case PD is not viable, and then, just understand there is no backup for PD. If PD can't be done at home, there is no in-center backup. So.
And my fellow PHN, Linda, brought up the transportation issue because I know a lot of the clients that I've worked with, they were okay to go on the handy van to the dialysis, but afterwards they were kind of weak and everything. And then when they took that handy van back, they collapsed, bad things happen afterwards. So if you don't have a family member that can transport you after dialysis, it can be a problem. And I don't know, do you do the shots anymore? Hemoglobin, the low hemoglobin, because I know used to be, I haven't heard about it lately, but there'd be family members that didn't want to give those shots to their loved one every day. They had a big issue with that. They wanted somebody to come in and just give the shot because they didn't want to do it.
Yeah. So that's part of our chronic kidney disease care is we do administer through Puitin. I just refer them to the infusion centers, like either Pulmonary or Straub infusion center. And then I typically use long-acting ESA.
That's good,
so they can be dosed once every 2 to 3 weeks.
Those Epogen shots, they just, a lot of families just had an issue with it.
Yeah. But it can be administered at home too.
Yeah, they
so
didn't.
Our home therapy patients give themselves their own ESA. We call it ESA, erythropoietin stimulating agent, so ESA therapy.
Okay, the next one is, does eGFR ever improve?
Well, it depends what's causing decline. I mean, so we can separate a decline in the GFR. There's acute kidney injury where there's a sudden insult to the kidney, and then there's chronic kidney disease, which is a more insidious gradual decline in GFR that occurs over many years, and that usually doesn't improve. But if there's an acute insult to the kidney, that often will improve, maybe not to the previous baseline. It just depends on how hard the kidney was hit. Again, I liken it to a concussion, right? Like when you get a concussion, you improve, but maybe not quite to where you used to be. And if you keep on getting more of those concussions, it increases the risk of having permanent damage later in life. And so every time the kidney gets hit, it gets a concussion, the GFR declines, and it might improve, but those hits accumulate over time. So very, very, I use the concussion analogy because I think it's a fitting example of what occurs in the kidney in the long term.
With cancer patients undergoing chemotherapy, which type of dialysis would you recommend?
Well, I presume for a lot of our patients, they're already on dialysis and they develop cancer, so I don't necessarily transition them to a different modality. Some of it depends on where the cancer is. So I'll give you an example. I have a patient who, wanted to do peritoneal dialysis. He had very end-stage kidney failure, but had kidney cancer also, and so was going to undergo radical nephrectomy, but wanted to do peritoneal dialysis, but that wouldn't work out because they're going to cut open his abdomen. So it just wouldn't work out. So, if it's an intra-abdominal tumor, or the patient has, pelvic metastases or a pelvic tumor, it essentially excludes peritoneal dialysis. Not necessarily because of the chemotherapy, but just because if you're going to be cutting open the abdomen, you cannot do peritoneal dialysis. as far as like chemotherapy and the types of dialysis, I don't know if there's necessarily a difference. I mean, I guess you could theoretically worry about infection risk with peritoneal dialysis, but I don't know if that would be enough of a risk to sway you one way or another. I don't know if it's ever been studied as far as outcomes. If one modality is superior to another in patients receiving chemotherapy, I don't think it's ever been looked at. So I couldn't give you an evidence-based response. Anecdotally, I don't think it makes too much of a difference.
I had another question. How you talked about the incremental peritoneal dialysis. Can you talk about maybe options regarding kind of incremental hemodialysis? Yeah,
that's another option too. Just again, your focus is not the adequacy. The focus is the patient experience. Because with all other dialysis patients, the focus is the adequacy. We have to hit the target because we are judged by achieving target minimum clearance dialysis or not, a KTRE of 1.4. And we base the dialysis prescription so that we achieve a target clearance level. We check it every month. We report it to CMS, and that's how we're judged. But with incremental either PE or hemodialysis, the focus is not the adequacy. The focus is the patient. And you want to provide enough dialysis where you control symptoms of uremia, but even if that means not achieving target KT/V values or URR values, which is the metric that we use to assess adequacy, the numerical metric that we use. So there's a lot of options. You could do twice a week dialysis, hemodialysis.
Yeah, that's just another way. I'm just thinking we can sort of advocate for our patients. Oftentimes in nursing facilities where I practice, right, you have these patients, they're washed out after hemodialysis and they're basically, or hypotensive, they can't get up, and it just wipes them out too much. And then, maybe we need to just sit down and talk with the family about, maybe doesn't mean getting rid of it, but maybe it's time to discuss with the nephrologist about.
Yeah, I think the incremental dialysis, maybe, it probably works better when you're dealing with home therapies because the dialysis units, they have patients and schedules and, you're a Monday, Wednesday, Friday, or you're Tuesday, Thursday, Saturday. And if you're only a Tuesday, Thursday, but not Saturday, then no one can take that spot. And, because no one's, so it's like for just Saturday alone. So the dialysis units, just because of scheduling and things like that, they may not be as open. But when you're doing home therapy, you're doing the dialysis at home. There's more of an option to alter the schedule, to shorten the time, to change the time or the frequency.
Any other questions or cases people want to share? Conundrums?
I guess one of my questions was, so blood pressure management of patients going into dialysis. Because you don't want to. I understand that you don't want too tight blood pressure control going into dialysis because you're going to take off fluid and then the patients, will bottom out. So is there? I know I don't know. We always talk about like not treating the number, but is there like a certain blood pressure range that going into dialysis that is okay, like keep it above 140 or
not so blood pressure control, there's not one size fits all. I mean, like that second example I gave with the peritoneal dialysis patient, her pressures were really in the 150s, 160s, and once we normalized her blood pressure with PD, she just was unresponsive. She needed the higher perfusion pressure. Now, obviously, that is not an evidence-based answer. I mean, the SPRINT trial and the 2017 AHA guidelines, recommend, primarily for stroke risk reduction, right? You want to target a blood pressure lower than 130/80, preferably in the 120s. But, I think in our population that we're talking about here, really, I don't want them to have a stroke. I don't want to intentionally cause them to have a stroke. But if achieving target blood pressure based on the AHA guidelines is causing them to be unresponsive, then it's not something that we can meaningfully achieve. The pre-dialysis blood pressures are not reliable, and neither are the post-dialysis blood pressures. The pre-dialysis blood pressures reflect a period of time when the patient is extremely volume overloaded just before they're starting dialysis. And likewise, the post-dialysis blood pressures represent a time when they've just had 4 kilograms of fluid and salt removed. And so neither is truly reflective of what their probably true ambulatory blood pressures are. So if you really wanted to know what their true blood pressures were, you really need to do ambulatory blood pressure management, monitoring, and send them home with the 24-hour, blood pressure monitoring, continuous blood pressure monitoring. Yeah, I guess a quick and dirty way is, well, can't you just average the first blood pressure and the last blood pressure, and then whatever the median number is, you can maybe assume is what their average blood pressure at home is. And I don't think there's a right or wrong answer, but that's generally what I do as a quick and dirty way to try and assess what their blood pressure is. Obviously, if they're coming in with blood pressures in the 200s, they're going to pop an aneurysm, and that's dangerous. So we cannot allow that. But if they come in with a pre-dialysis blood pressure of 160 and they leave with a post-dialysis blood pressure of 110, the truth is probably somewhere in between. If we try to give them more medications to lower the pre-dialysis blood pressure, we run the risk of having them have hypotension post-dialysis, right? So it's like damned if you do, damned if you don't. And so, yeah.
Okay. Thank you. I think, it's no easy one cut.
Yeah, it has to be individualized. But you don't want to allow crazy blood pressures. Like you don't want to intentionally allow an aneurysm to rupture or something. Like having hypertensive emergency, Wow.
Thank you.
Yeah. Any other questions out there? Let's see. It says something.
If someone is on hemo and they wanted to go on a trip, what are things they need to consider?
Well, so if they want to go internationally, they have to pay out of pocket. So they pay per dialysis treatment. So if they want to go to the Philippines or Japan or Thailand, they have to pay out of pocket. I don't think it's that much. I mean, it's a lot, but it's probably a couple $100s per treatment. And then I think for like Philippines, for example, if you want like your erythropoietin, you have to pay out of pocket for that. International travelers, especially to like the Philippines or Thailand, you have to watch for dialyzer reuse, where they reuse the dialyzer. Here in America, we dispose the dialyzer every use. There, they use it, they disinfect it, and they use it again. And so that may not be the most sanitary practice. So that would be something I would make sure to ask the international unit, is if you do dialyzer reuse or not. But be expected to pay out of pocket for international travel. For domestic travel, anyone in the US, we just need 30 days notice to arrange dialysis wherever you're going. That's for in-center dialysis. If you do home dialysis, like either home HD or peritoneal dialysis, we do need some advance notice so we can ship the supplies to the hotel you're staying at or to the place you're staying at. And then you can do your home therapy either in the hotel or at a relative or friend's house or the Airbnb, whatever. But we just need advance notice. So there's no real limitation on travel. I mean, just physically, you just have to make sure you're up for traveling, because I'm not on dialysis, but I get pretty wiped out when I fly to New York. I mean, I'm like wiped out for a couple of days, and if I were on dialysis, I mean, physically, I probably would be even more wiped out.
Right. I think we assess that, right? The facility and the destination, whether or not the facility would be in their network. Any comments have you facilitated travel with dialysis?
I know a lady, I didn't do it, but the lady wanted to visit her daughter on Maui, and somehow they arranged for her to have her dialysis on Maui.
Yeah, it's really common. I have patients going to Las Vegas 3 times a year, 4 times a year, and it's not an act of God to get that set up. It's fairly standard. Obviously here in Hawaii, we have a lot of people coming to visit us, right? Who do so there's an exchange of patients, and so our group takes care of a lot of travelers that come here for a week, and they do their dialysis. They go spend the rest of the time on Waikiki Beach.
Insurance plans.
Yeah.
Anybody want to comment on, because there's a lot of medication, like suddenly you have an addition of at least 5 or 6 medications, right? And the challenges of juggling all of that. Anybody want to comment on any challenges you face in medication management out in the community?
Well, I was just saying that I had that one lady that had several medication, the same medication, but all different dosages and things from different nephrologists and her PCP all there together. And me going in, I didn't know which one is she really, should I follow the most recent or, so I had to work with the doctors a lot I don't think they realized that this was happening, that she was getting all these different meds from different doctors. The same medication, but different dosages.
That's a big issue. And then, there's a lot of medications that need to be dose reduced or stopped. Like, metformin would be a good example. Insulin requirements change just prior to starting dialysis and then after starting dialysis. So, patients will sometimes become hypoglycemic, just when they have advanced CKD, but they're not on dialysis. And then, so just.
Right. And just being aware of which medicines are dialyzed out.
Yeah.
And so I guess we just call our friendly pharmacist and just say, hey, help.
Yeah. And even on top of that, like, there's a huge pill burden too, because presumably, maybe you have cardiovascular disease, diabetes. That's 9 medications there.
Actually, one thing I want to highlight is there are a lot of medications that are continued when patients start dialysis. So these medications are started pre-dialysis when we were trying to keep them off dialysis. And now that they're on dialysis, they no longer need to be on them, yet they continue on them indefinitely. Like sodium bicarbonate, for example. I see a lot of patients who are on sodium bicarbonate to manage rheumatic metabolic acidosis, and then now they're on dialysis. Now I can adjust the bicarbonate with the dialysis. I can correct it. But yet they're on 1,300 milligrams TID of sodium bicarbonate. That's like 6 pills a day.
Waste,
It's like, for no reason, because I can fix that with the dialysis. So just to make sure both, there is polypharmacy, there's a lot of providers, a lot of hands in the kitchen, but also to make sure we stop medications that they no longer need to be on because they're on dialysis. So I think every patient who starts dialysis needs a very thorough medication reconciliation and to pull off any unnecessary medications.
So would you coordinate that with the physician? Because the medication itself is so complicated, not only for a patient who's cognizant, but also for the family members, the support system. So if you were, would you coordinate with the PCP to suggest that they discharge the?
Yeah, well, a lot of times when patients start dialysis, we in some ways become the de facto PCP.
Oh, okay.
Yeah, so I find that we become in charge of the med list at that point. I mean, it's kind of this unspoken thing, but we end up managing it. And, we round on the patients. Well, our nurse practitioners round on them every week on dialysis, and then we see them, generally about once every quarter, because the nurse practitioners are fully capable of managing things. They do med reconciliation, and when I see them, we do med reconciliation in the clinics. We try to pull off whatever is unnecessary at that point.
Yeah, I think we answered that question, about the polypharmacy issue. Yeah. Chad, what role does pharmacy play, do you find?
I think one of the challenges in the community, though, is just the way that the healthcare system is set up, and pharmacy tends to be, lack of a better word, like out in left field sometimes, because our computer systems are designed for for dispensing, but it's not designed for a clinical assessment. So, even some of the questions that we may have in the community CVS for our physician friends, like, we can't really formulate a great question because we don't have all the information ourselves. So I think it becomes really challenging when we see a med, we suspect that the patient has CKD primarily because of the med list. And you want to make a suggestion or recommendation, but you can't because you only have 30% of the information. And so that becomes very, very challenging from a community standpoint, in my opinion. But if you have the benefit of working in a closed system like Kaiser or the VA or the DoD, or even in a hospital, then I think that we have a lot more, a bigger role to play and can offer more assistance. But yes, didn't really answer the question, but I guess it depends upon the system and how we're integrated within that bigger system.
It says a lot about how we need to change our healthcare system.
Oh yeah.
Oh yeah. I mean, I have students ask me all the time, like, well, how do I know if this medication needs to be renally adjusted in community? And I'm like, you don't. That's a thing.
Really challenging and dangerous.
And very dangerous.
We have another question here. Dietary restriction won't improve GFR, but rather stem the decline?
Yeah, I think, definitely high protein diets. There was a large study in China. I mean, we've kind of knew this from rat studies early in the 80s. They did rat studies with CKD progression and high protein diets. And they did find, rats who were fed high protein diets did have a quicker decline in GFR. Then in the 90s, the MDRD trial, it wasn't designed to look specifically at dietary intervention and decline in GFR, but it did show some benefit with protein restriction. And then, a large population-based study out of China that looked at 25,000 patients several years ago. When they looked at patients who, doing dietary surveys who ate high protein diets, high meat, pork, beef versus more vegetarian diets, we did see higher rates of CKD in patients who had the high protein diets. But dietary restriction of protein is a double-edged sword because on one hand, the GFR is an important metric, but malnutrition and protein malnutrition is also a very important metric because of all the risk factors, like for example, in our dialysis patients, of all the numbers we check, one of the most strongest predictor of survival is the serum albumin. So we don't want to restrict dietary protein in order to improve, say, the phosphorus or the decline in GFR, but at the expense of their nutritional status, because poor nutritional status is an adverse prognostic factor in patients with CKD and on dialysis. So it's kind of a double-edged sword. So I recommend just kind of a moderate dietary protein restriction. I generally recommend patients to try to avoid red meat, try to avoid pork. Some fish and chicken in moderation is okay, but to get majority of their protein from plant-based sources of protein, that tends to be a little more friendly on the kidneys and on the phosphorus. And then while still maintaining adequate nutritional stores of protein.
Is there a target albumin level that we should look out for?
As close to normal as possible.
Close to normal.
Yeah, 4. As close to 4 as possible. But it's challenging. A lot of our patients still have residual renal function, so they have proteinuria, so they're losing albumin right through the proteinuria. Peritoneal dialysis, you lose albumin through the PD. So sometimes it's hard to maintain the albumin on peritoneal dialysis patients.
Any other questions, thoughts? Great. All right. Thanks so much for joining us. And let me see. Let's wait before you go. Conclusion. Right. So in order to get CME credits, go to our webpage, complete the online evaluation form, indicate the type of CE that you would like. And the link is also found at the very bottom of your email invitation. And your comments are very important to the planning committee and will be used to plan future programs. So tune in next month, January 8th, 2019. Our topic will be cancer screening in older adults. And we have a guest speaker, Dr. Louise Walter. So look forward to seeing you again next month. And please think about and come up with cases for discussion. Thank you. Have a wonderful holiday.